Hello, Dr. Gallina. This is Dr. Harb, President of MMG, interviewing Dr. Gregory Gallina, one of the pioneers of surgery for medical education in the States. I'm welcoming him to introduce you to him. He just joined MMG board he's going to be the director of surgery clerkships in MMG for residency and also for any kind of post-residency experience like fellowship or counseling for fellowship and even practicing medicine. He has a very rich history, academic history and personal history, definitely. I'm going to leave the floor for him very shortly to tell us about his experience. For those who are interested in getting into residency program, I will advise you definitely to try his rotations. On top of that, he's going to be responsible for the career counseling for those interested in surgery and surgical specialties for the future. Dr. Gallina, how are you? Welcome on board, and I'll be very glad to have you with us.
Dr. Harb, thank you. And we discussed this offline. I'm very excited about this opportunity. I think that, really this is the project that we're embarking upon is important, a big project, important project. I'll tell you a little bit about myself. I'm an American citizen. I grew up here of Italian heritage, but my parents have been here for many years. Graduated college, started medical school in Naples, Italy, spent 3 years in Naples, and then transferred, finished my training at George Washington in Washington, D.C. Did my surgical residency at what was then UMDNJ, now Rutgers, New Jersey Medical School program. Did a colorectal fellowship at SUNY, State University of New York at Buffalo. And then I've been practicing. And since I was, I remember when I was in medical school, I met you meet a lot of people, but I met one gentleman who interested me greatly. He was a urologist, and he was a practicing urologist, busy, had a private practice, but he was very involved in the residency program and the student teaching. And getting to know him a little bit, I was like, someday this is the guy I want to be like. And that's kind of what I've set my goal to be. So over my career, I've been involved in the education of both students and residents. I've worked with them as a preceptor, as an instructor for my entire career, but I've been fortunate enough to formally educate them as well. I was the student clerkship director for medical students, the site director at Hackensack for 19 years. And then I was a general surgery residency program director for 3.5 years. And so those are really some very rewarding experiences. And I think that, as you and I have discussed, I think there's some experience I have that I can really help our students with and bring to a new group of students to help them understand how to navigate the waters and to the way that they can set themselves best up to succeed.
Very good. Excellent. How do you think the difference between like having this kind of rich history with medical students, medical education and residency, what do you see different between all the, let's say, students before the 2000 and after the 2000? Like, have you seen any kind of difference in kind of mentality, approach? If you can give us a little bit of the way you see them and what we should expect next.
I think it's a very interesting question. And I think there's a lot of debate about how much different the students are now than they were before. I think they have constraints put upon them that may not necessarily be in their best interest or in their education's best interest. And I think a lot of them, some of them are even frustrated by it just from working with my own students and residents, the work hours and this and that, and so many rules, the didactic time. Some of it is imperative and necessary. I always reminded my residents that until whatever they did in the operating room, whatever they did in the wards, however great they were taking care of patients, if you're not passing the exams, you're not going to get a job. So the didactics and the education part has to happen. We can't have doctors who are overworked or who are going to be sloppy or who have problems. So we have to watch how much they work and try not to push them to the edge of a limit. So those ways are a little different. I think some of them, in my experience, quite honestly, a small percentage of them have more of that, it's not necessarily a compliment, it's some of the millennial attitude where they, want to work shift hours and want to come and go and have days off and weekends off. And all of us want to have that. But I think for the most part, their dedication to the profession, in my experience, hasn't changed greatly. And I'm thrilled about that. And I'm not sure I'd be still doing this if I thought that were different. I think these young people are still as dedicated, as motivated to help others and to advance medicine as we were when, back in the last century when we were students.
How do you describe also your experience with IMGs, international medical students and graduates, compared to the American students?
Well, this is a constant conversation we've had, and I've I think one thing I bring to MMG and that I've always worn proudly in my career is that I've walked in both places. I had an experience as an international medical student, not a graduate yet, but I did work. I was an international medical student and I was an American medical student. I think one thing we notice about the IMGs is they're very driven. The American medical students, for the most part, are very interested in succeeding, and they're good students and they work hard. But the IMGs, if you pardon the expression, have a certain chip sometimes on their shoulder where they feel like they really have to prove themselves because they even still to this day, the same as we have sometimes with DOs, the IMGs sometimes get this negative connotation that, you're just an IMG, or you have some sort of inferiority from or even a perceived inferiority. And I think it really motivates them to work hard. In my experience, motivates many of them to work harder than the average students.
And do you think is there any kind of specialty other than primary care IMGs cannot get into nowadays, or all are available? I know some of them are very difficult, like ophthalmology and dermatology, but I'm talking in terms of surgical specialty. Experience as the director of Surgery Residency Program, do you have any kind of restrictions, like psychological restrictions or academic restrictions for any IMG to get into surgery or ER residency?
In my opinion, and having done it as from the other side again, right? So I've done it as the person applying and I've done it as the person reading the applications. I think for counseling my students, certainly even the best American allopathic students, if they're thinking about a career in ophthalmology and dermatology and orthopedic surgery, neurosurgery, maybe ENT and urology, those really are the only ones where we just tell them that they have to have some sort of backup plan because the selection process is so difficult, right? Outside of those specialties, there's the upper cusp of the matching specialties. I think there's no limit to what the IMG should be able to accomplish. I've accepted IMGs into my own residency program. I've seen them now become senior residents. One of my really good friends is an IMG who's a practicing surgeon in the area who's incredibly successful. Like I said, when you see the applications, you meet the people, and even ignoring this test score, when you get to know them and you watch them work and you experience them, there's not a perceptible difference. And I think that it's very important that we make sure that the young people know that they really should not set their sights low. They should pick what they want to do. If they're doing something that they know is going to be a tremendous challenge in their position, then they should have a secondary plan. But it's the same exact advice I gave to a friend of mine who's an anesthesiologist whose son was an American medical grad who wanted to do orthopedic surgery. These are hard things to get. There's a lot of things involved besides your skill and your personality and your letters. There's a little bit of luck involved, and sometimes you're not lucky. And you have to prepare for something. But I also tell I've had applicants to my surgical residency who didn't match in plastic surgery and neurosurgery, and then they said, some were more genuine than others, but some wanted to do general surgery. Some even would come to a general surgery residency hoping that then they may be able to either leave in the middle or finish and find where they want to go. The only thing you really have to do though is work hard and continue to prove yourself. And I really think that even except for those couple of specialties which are not unattainable, but the most difficult, except for those, the same opportunities exist for IMGs. Granted, the hill is a little steeper, but it's definitely achievable. I can tell you that during my tenure as a program director, when I had my rank list, I had international medical graduates probably in my top 10 on my rank list, and not just from St. George's, which is kind of a much more known commodity than the other medical school. But I remember a kid from Ireland, and he was just a terrific young man, and he had a great resume, and he presented himself well in an interview. People liked him. I think doing rotations in American hospitals where faculty can speak up for you is irreplaceable, especially for the more competitive specialties.
This was supposed to be my next question, actually. What are because we know, and we always tell our students, the LOR, letter of recommendation, is the number one that can get you in or out because it shows actually your character and your experience in the States. But as a director of Surgery Residency Program, what was the main components, or what was the main criteria for you to accept or reject a student?
Well, I'll give you an example, and we're on video, so I can give you an example from one of my mentors. He was the chair of urology in medical school. And he would always say that academically, all the candidates can be separated by this. He goes, they're all similar. There's a thin line everyone who's gotten to this point, who's graduating medical school, international, American, wherever, if you make it to where you're graduating and you're able to pass the boards academically, there's statistically no distinction. So what makes a difference? For me personally, and some of my colleagues that I know are program directors, what we spoke about, letter of recommendation. If I have a student who comes to me and I look at their file and they have a unanimous two or three letters from physicians they've worked with who say, listen, this person's really good. They did all the work. They made no waves. They always were prepared. They always were eager. Though that went the longest way. Their personal statement, if they have if there's a unique part to their life story, I think that helps. The grades were the grades, but more than the grades, again, their comments in their medical school letter from their preceptors on their clerkships. You want to see, what I wanted to see as a program director was somebody who, one, would come in and do the work. That's the easiest part, actually. Two is come in and not cause any problems in the hospitals and with their colleagues. That's the trickier part. And third, somebody who's going to succeed and be academically strong enough to pass the boards when it's all said and done.
Do you think actually for the future, do you think surgery as a career or as a resident, not just a residency, as a career? Or we're hearing with the AI and the technology, surgeons will be less demanded in the future. It's going to be mainly AI and mainly like technicians more than surgeons. So is there any kind of risk or danger for the surgery as a career?
I think that, there are certainly some careers where it's going to get challenging. One of my colleagues who's a radiologist said that hurt the radiology applications, is the fear that AI is going to read the x-rays. Mm-hmm. And I'm going to talk about that a little more in a minute. I think surgery now, even with robotics and 3D visualization that we see on imaging, I think to get to the point where those are going to be able to be applied to physically being able to do the procedures is a long way off, especially not with firsthand observation and assistance. So I don't see that in our lifetime. The other thing is that I always tell the patients as well as the colleagues is that everyone is so different. How many people do you know with the same face, right? I have identical twins. Their faces are very close, but not the same. How many people do you know who are the same height, weight, and body shape? People vary. Anatomy varies. Physiology varies. I'm not sure that we've come to the point where an AI model will be able to not just make those decisions in advance, but really to change them on the fly, or to understand that, right hepatic artery is coming off the left hepatic artery instead of the common hepatic. I don't know how, I'm sure theoretically there can be enough computer power to realize that, just like the mind can realize it. But I don't know that next step is in the short term anywhere for the people who are starting on a career now, maybe for the kids in grammar school.
What made you join MMG?
Thing that struck me was reading through this, the physician shortage we're facing in America. I think that's one thing. And then the other thing is, like I said, I have some experience as an international medical student. And I think that I think there are these many capable young people who are out there, who are capable and who are potentially, really can offer something and who are exceptional. And I'm not sure that they have a streamlined means to get to their goal. And I think that for what we offer is that we're going to try to give them a playbook, some sort of a syllabus of what to follow so that they can get to their endpoint. You want to be an American physician? Okay, you need to do X, Y, and Z, right? You need to have citizenship or a visa. You need to have or a green card. You need to pass the boards. You need to get some letters of recommendation where people read them and say, "Oh, I know this person. I'll help them." You need to have some experience in American hospitals or with American doctors. If you want to practice in America, I think that's imperative. And I think that's what we're here for, right? We want to give people the means to use the process of becoming a physician, where each single student doesn't have to reinvent the wheel every time.
How do you describe day-to-day rotation details for surgery rotations? What should they expect from their surgery rotation?
The surgery rotation is different than the surgical versus the non-surgical rotation is different, right? Because we're going to do procedures. That's not the most important, but it's an essential part of the rotation. So there's time where they're going to, I think it's very important for them to understand how the patients get to us, right? We see them in the office, we evaluate them. They either come with a diagnosis or we find their diagnosis of a disease that needs some sort of intervention. And then the next part is witness the intervention, right? To see, to observe or sometimes participate in the surgical treatment, right? The operation For me, I do colonoscopies as well, the endoscopic, be it minor operations, anorectal operations, or major operations, and then at least a little bit of the post-hospital care. Things besides diagnosing and treating them. Unfortunately, every patient just kind of the same theme, right? Every patient doesn't recover the same, just like every patient isn't the same. Some patients recover quickly and easily, and some patients have a more challenging course, and some patients get complications. The axiom in surgery is the only two types of surgeons don't get complications. One is the ones who don't do surgery, and two is the ones who lie. The rest of us all get complications because we do so many things to avoid them, but you can never make it zero. That's the human condition. So I think for the students to have an understanding of kind of what can happen afterwards. So I think hopefully we have a robust clerkship where they feel like they get preoperative care, understand the surgical treatments, the postoperative care, and then finally, of course, a didactic experience, right, where we make sure that they're going to be prepared academically as well as surgery. Despite what some people say, surgery is not all technical. It's extremely academic, and understanding how much the academics are involved is important as well.
What's your final advice and word for students joining our program, especially students who are going to join you very soon? Our students in general, MMG students, and specifically surgical students.
I think the important thing is we started and we're building a faculty of people who have experience with international students who but have success in the American medical system, right? Those are two very separate things. So we experienced the international medical student. We understand what international medical students go through. We've passed the other side of succeeding in the American medical system. And now the last thing is with their help, we're going to try to replicate that success, right? And we're going to try to grow a group and really, and this is something that I think that you and I will talk about more, but really also a fraternity, right? A group of people who shared a like experience, who now when they're out 10 years from now, and please correct me if I'm wrong, 10 years from now, if they're in Montana and they find out that they have a colleague or a family member, a patient's moving to Carolina, and they have somebody who's an MMG physician in Carolina, I would like to think that they'd say, I met this guy. I know this guy. He's one of us. I know. So that what they've been through, and a little bit about like the demeanor they have because they've come through they've walked some of the same path. And you and I didn't really speak about this, so I don't want to overstep it, but I sense just from getting to know you that that's what you would like to hear. My last point on that last thing we spoke about too is you and I will also need those people to replicate us. To me, that would be a great legacy for us to have. Is that this going forward years from now, where there are more students coming with that brand and increasing. People say, "Gee, wow, this is a recognized way to bring qualified doctors to the States to help people who would be underserved because we know I'm not doctors."
I'm so happy to have you, Dr. Gallina. It has been our pleasure and honor to have you on board with us and to get your insights about the students and about the medical education for the international students. It has been very good conversation. We'll keep in touch. Thank you very much again. Thank you for
absolutely my
joining
pleasure.
us, and thank you for having this with you today.
My pleasure.
Thank you.
Thank you, Dr. Harb. Bye-bye.
Bye.